With that, I think we're going to move right into the first presentation, which is Dr. Kevin Sherin. Dr. Sherin was the health officer for Orange County, Florida, with the Florida Department Statement of Health. And he was also instrumental in helping us pull off the first couple Amoeba summits. And he's going to go a little bit deeper into the public health perspective of the amoebas in Central Florida. Dr. Sherin?
Okay, that's the pointer, huh? Advance the slides. Thank you, Steve. It's an honor to be here at the 4th annual PAM Summit. So I'm going to talk to you about the public health aspects of PAM, primary amoebic meningoencephalitis, Naegleria fowleri. And I'm going to start off with a quote from the Lakota people, which are the Plains, Native Americans, First Nation people. The ones that matter most are the children. So we dedicate this to all those who've been lost to this deadly amoeba. Now, I would also add that we believe that from a public health standpoint, there are probably many other individuals who've been affected by this. So public health's role is to do surveillance and detection. And we rely on the clinical and laboratory systems to confirm the detection. So I will run through the slides if they work. All right. So neither myself or my immediate family have any relevant conflicts to disclose of any interest. We are not in this for financial gains. We are in this to promote, protect, and improve health. So today our learning objectives will be, and this somewhat summarizes the entire conference, I would think, recognize the differences between a clinical case definition and a public health case definition. Review the epidemiology of PAM, or Naegleria fowleri, and its changing geographic distribution. 3, recognize which states now require public health reporting of PAM. And 4, to recognize some environmental and other risk factors for PAM infection. So the case definition of PAM, quite simply, if we were going to do a clinical definition, it would be our clinicians that would do that. The signs and symptoms and clusters and looking for that laboratory confirmation in the CSF would be the clinical picture. Tragically, in many of these instances, we are very late to identify that organism, even if CSF specimens have been taken. And parenthetically, if a child presents to the ED or an adult and only has headache and fever, it's probably pretty unlikely that they would get that tap if they didn't have the meningeal signs, the clinical signs of irritation of the meninges, the stiff neck that Steve described for Jordan. Now, the case definition from a CDC perspective, and oh my goodness, I have Dr. Cope sitting here, who's the CDC expert. It's really just the clinical cluster plus the laboratory confirmation. You need both. But I would be remiss if I didn't tell you that we ought not wait to treat based on what we've learned about this disease over the years. It is the early treatment that makes the difference. So in clinical medicine, if we suspect meningitis, we're going to reach for ceftriaxone as a medication. That's been done for years. Well, in this instance, if you suspect, if there's freshwater exposure and you have the clinical signs and symptoms, you should not wait for laboratory confirmation to begin effective treatment. So that freshwater exposure plus clinical signs that are suggestive, headache, fever, can lead you to intervention at an earlier stage. And the idea is that earlier intervention is going to make a difference. So our public health apparatus is designed to help us know about these early cases. In 2016, the CDC required people to report to them and call the hotline to obtain an effective medication, a newer medication that's being applied, an older medication for anti-leishmaniasis and cancer treatment, which is the drug known as miltefosine. That's no longer the case. Miltefosine is commercially available, so you don't have to, call the CDC to get this medication. I'll just get this out of the gate. But you can pre-position it in the emergency department. Now, for many years in the United States, and we've had at least 146 cases reported in the United States, and this data is a little bit old, so Dr. Cope, I would hope, can bring us up to date. You can see the geographic distribution has expanded beyond our southern tier of states. And Florida and Texas have had the largest number of cases. So they've had probably the greatest level of awareness of this disease. As Steve said, in 2007, when I was the health officer here, we had 3 cases affecting Orange County in one summer. And that naturally, CNN was on our doorstep. What's going on? But the fact of the matter is, this can be found in any of the U.S. states, and I believe the reason we aren't identifying it in all of the U.S. states is simply the matter of reporting. So, to the point of which states require reporting, Florida was one of the first. Today we know that Florida, Texas, and Louisiana require reporting. And that's a key component of the public health system's response. So public health can be defined as community-organized efforts to promote, protect, and improve the health of the population. In this instance, what matters most is the children. We're not neglecting the adults who can also get this. And we need to be about promoting the prevention and protecting people who are swimming or using neti pots. And you'll hear the different forms of how they can come in contact with this fresh water, unchlorinated, that goes up the nose and results in the infection known as Naegleriasis or Naegleria fowleri. Now, do you think it's unusual that Alabama has never reported a case? I do. If it's only the southern tier of states and the warm water, well, why is Minnesota reporting? Why is Kansas reporting? Why is Maryland reporting? Why is Indiana reporting? Why is Virginia reporting? Gosh, those are not in the southern tier of states. California is reporting. You get the point. This can occur in any of the U.S. states, and I think that in Europe, we saw that same thing. And we can talk about the international data a little bit. So this map is color-coded to tell you where most of the cases have been, and literally close to half of the cases have been in Texas and Florida. So I do think there's greater awareness here, and that's something that public health can do. We can promote awareness, but all of us can. The community can do that. And that's the primary prevention. We don't want children wakeboarding or water skiing and slamming their head into the water when it's warm and not to know about the risk of this. As a public health person, in my major part of my career, I'd want all the children to wear nose plugs. But are you going to get them to do that? Do you think? So, the reportable disease is by statute in Florida, Texas, and Louisiana. Hence, 47 U.S. states and 5 U.S. territories, dare I say, do not require reporting. How are we going to know? I know a pediatric neurologist in town. When he was in the military, he served in Limestone, Maine. near Caribou, Maine, in the Air Force. And he said, quote, "We saw these kids all the time. They were swimming in the quarry." Has Maine ever reported a case? No. I grew up in Massachusetts. In the 1930s, they dammed up a river out there and created a reservoir for the Boston area. What was that? A very shallow lake. It's called the Quabbin Reservoir. Physicians in Massachusetts who are older tell stories about, yeah, we remember kids swimming in the Quabbin Reservoir. We had 10 one summer who died of this. Has Massachusetts ever reported a case? No. Dr. Cabral, who's sitting in the front row, is aware of a study from 1970 in her own community of Richmond, where the pathologist reviewed the case material from years back, and they discovered that, yes, there were other cases of PAM that had never been reported. So I think the take-home message I want to get out for a public health perspective, we can disseminate information on the reporting. This conference is actually being streamed globally. Thanks to Dr. Wilson, who's in the back, the World Medical Association has an article coming out on this. And our group, which was involved in writing a paper for the World Medical Association journal, are recommending the WHO take a look at this. 11 people in Karachi have developed PAM in the last several months, and that's not atypical. So it's a global disease, it has global impact, there's global travel, Costa Rica to Orlando. How does that ED physician know about the nature of this disease and the likelihood of an infection? Only by increasing awareness. Only by increasing awareness of that rapid laboratory confirmation. Only by increasing awareness of the effective treatment. Only by pre-positioning the medications. And we have saves all over the world. China, India. Medscape, thank you also to Dr. Wilson, I'm sure, which is a derivative of JAMA, the Journal of the American Medical Association, has a paper in 2019 about this disease. So I think the word is getting out. We're increasing awareness. And Steve, this is a result of this summit to a large extent. I have to believe that, as it was with Sebastian's case in 2016. So I believe that it's implausible that Mississippi has never had a case. Now we can see that Alabama has reported, but you get the point. So warm, freshwater exposure where it goes up the nose is classic, but warm water temps may vary, and water temps may vary. What is too cold? What is too hot? More than 115 degrees? No. It's not going to, the organism will not thrive. The trophozoite form of the organism won't survive. But there have been cases in the winter in Florida, and when I look back in the history of this state, so what is too cold for this organism, for the trophozoite form to survive? Municipal water supplies have been affected. Arizona, Australia, Louisiana, and resulted in people getting sick. It was the very first case in Australia that was described by Dr. Malcolm Fowleri from the Adelaide Children's Hospital back in the early 1960s, and that's how we got the name. It was Malcolm Fowler, he was the pathologist in Adelaide, and that's how we named the organism, Naegleria fowleri. We've seen cases involved with diving and wakeboarding in lakes, splash pads, lawn hoses, ritual nasal ablutions. I'll hit the pause button. So in the Islamic faith, people are asked to do daily ablutions, cleaning, and one of them is the nose. But think of the water that gets used. Is it properly distilled? Is it saline containing? What does the faith require as far as the ritual? But let's say it's taken out of a river. And that's, I think, what we're seeing in Karachi with 11 cases right now in a breakout. We also have something called neti pots that people in the United States use. How many people here have sinus problems? Come on, don't be ashamed. Yeah. And so a lot of people use what are called neti pots to help clean out the pollen from their nose. Guess what? You need very specific directions on how to prepare the distilled water and how to clean the neti pots. That can be part of the public health messaging as well. Could the neti pots have warnings on them? Certainly. So it's risk communication. Risk communication is another part of public health. Inadequately chlorinated swimming pools. So do we have to worry about the swimming pools? Really low probability, but if they're not properly chlorinated, guess what? If the pool is turning green, that's not properly chlorinated, right? The pH, the water chemistry is not right. People need to meticulously take care of their swimming pools, and that includes public swimming pools. So yes, there have been cases of PAM identified from poorly chlorinated swimming pools. And now, why is the epidemiology changing? Why in the last, 10, 15 years have we seen more northern tier of states in the United States? Well, you could say it's partly because of awareness, but I would also postulate that the climate is indeed changing. When the Arctic sea ice is now 150 miles from Barrow, Alaska in the summer and in the month of September, something's happening. And the Greenland ice sheets are retreating. Something's happening at the global level. So we would expect this disease to move into the temperate zones. And it isn't only subtropical areas, let's say from Tennessee to Florida, that need to be concerned. And we also have the anecdotes from years gone by in other northern states. You don't need to wait for CDC to approve the use of medications effective for this disease. But they are there to support you. And I don't want to misspeak. People can still use the hotline, but it's not to obtain the miltifacine. They can have technical guidance from the waterborne lab. And I think Dr. Cope will speak to that. But CDC does want to know about these cases. So I'd be remiss if I didn't say that. Even though it's not required nationally to be notifiable, and we did bring this up to the AMA in 2016, as Dr. Wilson knows, the AMA did agree to bring up the promotion of awareness of this disease, which the Medscape article has helped to do. But we wait for CDC to give the lead, or the Council of State and Territorial Epidemiologists to say what's going to be nationally notifiable. I talked to I would consider him an epidemiologist in Tennessee this week. And he had been, chairman of the board of MMWR. But this is one thing on the radar. It's not the only thing. And so he was aware of the CSTE discussion in 2016. There's not a consensus among epidemiologists in this country. Epidemiologists are the public health professionals applying the science of public health, looking at the risks and determinants of the disease. So Florida is second only to Texas in the number of cases reported. We've had at least 32 since 1965. The first case ever in Florida was here in Orlando. I'm told that it was a pathologist named Dr. Butts at Orange Memorial Hospital. Today we know it as Orlando Health, who reported that. So back in the early 1960s, just like Malcolm Fowler in Adelaide, it was the pathologists that were beginning to see this. Tragically, most of the cases involve adolescents and really a preponderance of boys versus girls. Excuse the gender bias, but the boys are horsing around in the water, and they're more likely to be roughhousing and to get the water up the nose, or slamming one another's head into the water, truthfully. And that seems to be what the pediatric literature shows. But it's a 3-to-1 ratio of male to female in this disease. The rapid downward spiral that we heard about with Jordan's case is all too familiar. People can become sick immediately within 2 days, or they can go as many as 9 days or more before they develop symptoms. But it's that preceding exposure to fresh water that's pushed up the nose that makes all the difference in the world. And as I said, Orlando was one of the first ones out of the gate, but Virginia was looking at this as well. And I'm sure Dr. Cabral will speak to that. So, future public health policy directions. Yes, we need municipal water standards. We knew that from the cryptosporidiosis outbreak in Milwaukee, Wisconsin, where an entire city became sick. Suddenly 1 million people had diarrhea, and they discovered that they needed to have special filters in the water supply. So waterborne illness can affect large numbers of people. Now, you don't get Naegleria from drinking water. You do get cryptosporidiosis. The point being, that had to do with dairy cows in Wisconsin and contamination of the municipal water supply. The point being, this one can only be acquired by forcing it up the nose and what we call the cribriform plate, where it makes it easy for it to get into the brain, the frontal lobes of the brain. So we can have water standards for municipal water supplies. Guess what? That needs inspectors. It needs the Department of Environmental Protection. It needs the city inspectors. Let's use the example of the city of Apopka here. Pick on any municipality in our Central Florida area that has a municipal water supply. We have to be held to certain standards. And that would include the chlorination. It would include analysis for organisms, et cetera, et cetera. That's a public health thing. Standards. Pool chlorination standards. You know, in the state of Florida, we inspect the public pools twice a year. That includes all these hotels in Orlando. You know, there's something like 175,000 hotel rooms in this city alone, with 80 million tourists. You know, we have to be very meticulous about how we maintain the chlorination standards in the pools. As I mentioned before, we could have warnings on these neti pots. Seems to make sense. Do people read the warnings? Do they have to be in multiple languages? People ask all the time, why do we need warnings on the generators? Because every time the hurricane comes, people die from carbon monoxide poisoning. We constantly need to reiterate these messages. So the health risk communications, that's part of public health. Active communications campaigns. This conference is an example of that. 4 years in a row, bringing the best science, bringing the best practices, bringing the best information, and disseminating it. Whether it's Florida hospitals, I'm sorry, I knew I'd do that too. Advent Health laboratorians who've produced a video that all laboratorians in the United States or globally can use on the best techniques to identify the Naegleria the old way, with light microscopy. Laboratory standards for clinical facilities. That's public health. So somebody certifies the laboratories and says, okay, you're able to open the door. Could we simply say, you know what? This is a good idea for emergency departments to have for, quote, viral meningitis or non-bacterial meningitis. How many of those could have been PAM? They're poorly identified, you know, meningoencephalitis, and they died, and there was no autopsy, right? But could we have standards that say, you know what? We're going to add the N multiplex into the mix, and we're going to check for the Naegleria antigen. That's an example. So what are the laboratory standards that could be put into our standards for clinical facilities, clinical laboratory facilities? So I will close with this. And I'm trying to see the time and how we're doing on time. If anybody wants to ask any questions, I'm sorry, I do have to leave and go to the clinic to see patients, but you're welcome to ask anything that you might want to ask. Are there any questions? Okay, thank you very much.